here tonight discussing end-of-life options. And there's a lot here. If you have any questions, please let us know right away. I'd really like to make this a discussion open to all of you. And I understand you can see my notes, so you'll know if I leave anything out, and you can ask me a question about some of my notes that I'm not seeing tonight. So they told you who I am. I have worked at cancer support centers like Cancer Care. Here in Sherman Oaks, it's called We Spark. And I'm also a volunteer for Compassionate Choices. So they are the group that helps to set up, they've been an amazing group that helps to improve care, expand options, and they focus on the legislative aspect of working on end-of-life care across the nation. And so in talking about death, I like to say that it's not the opposite of life. It's really a part of it. It's a part of all of our lives. It's something that we're all going to experience, and we often experience it with our loved ones before we experience it ourselves. And we really find that the more we embrace the idea of death and what it is, the more that we're able to embrace life and what life is giving us at each step. So research tells us that we all want to die at home, but consider that 70% of Americans who prefer to die at home, only 25% actually end up dying at home. No one is raising their hands and saying they want to be in the ICU and have every test and tube possible. But we want our pain managed. We want to be comfortable. We want our spiritual values respected, and we all have that limit that we'll say that's enough. So it's really important that we deal with it and speak of it as often as possible so that those around us are comfortable with it also. I could do a whole presentation on advanced directives, but they really play a lot into what's been happening these last few years with COVID. Some recent research that's come out on advanced directives, how they failed us, how they've helped us. And so I'm going to talk a little bit about them, and I'll circle back, but I won't answer all the questions about them. But I want you to understand that advanced directives are that set of paperwork that you get worked out that first of all talks about who's going to be your advocate when you can't speak and can't speak up for yourself, whether it's comatose, whether it's a stroke, or dementia. Otherwise, you're going to be helping to make a lot of your own decisions as you go along, but we put a lot of emphasis on this healthcare advocate and our advanced directives. A lot of them spell out a lot of the decision making that we're making at this time, even though we know now that those decisions change as we age, as our disease progresses, and as a matter of fact, as we learn more things. So 82% of people say it's important to put their wishes in writing, but you can guess how many have actually done that. But we can start to break this taboo. Many people will be able to avoid dying alone and in pain in unfamiliar settings if we can avoid regrets and unresolved issues and bring impoverished and not be impoverished by end-of-life care by starting to have some discussions about what we do want and don't want. So let me get down here just a little bit. What we've been seeing a lot because of COVID is hospitals are packed. There are long waits in the ER. People have been putting off a lot of tests, colonoscopies, checkups, even elective surgeries. And when patients are admitted to the hospital now, a lot of them are going alone, and family members are having to make decisions via iPad or phone. So it's really more important than ever to have those discussions about what you want and don't want. And
Karen, if I may, I'm
Sure.
so sorry to interrupt. I just wanted to double check. We're still just seeing the first slide.
Oh,
I'm not sure. I'm not sure if you've been progressing your
yes,
slides.
I have. See, okay, now, where are you now?
We're still on the first slide.
All right, yep, I have been progressing. You can't move them either, huh?
No, and sometimes there is an issue with Zoom where it's just really delayed. So you're seeing something that we're not. So it might be a glitch with Zoom today.
It may be a glitch. Okay.
Yeah, but everything that you're saying is communicating really well. I'm curious if it would be how do you feel about going without the slides and we can either send them later or
Yeah, hang on. I know I have them right here. So while I'm talking, well, I'm not quite as adept of doing the am I still sharing right now?
you are not?
Okay, so tell me give me your address real quick and I'm going to forward it. I'll just forward it to you, Allison, okay?
That'd be great. I'd be happy to share your slides for you.
Okay, so they just went to you and I'm going to go on from where I was. And then as soon as you get them, if you could put them up, that would be great. Okay, am I still sharing?
Let's see, I am downloading them now.
Okay. And well, they're not very well numbered. I'm on number, it says 66 or number 7. I told you I played around with them a lot. So
not a
problem. Look here at my notes a little bit. Okay.
I know everyone's excited because there was, I think it said 119 slides, and that reads to us information that we want.
That's right. That's right.
So,
I have a whole bunch that are hidden. So
okay, no problem. It's loading onto my computer. So
okay, so if you're using that program, there are a number that are hidden. So it'll just advance from when you get to with number 7. So I was at a conference not long ago for end-of-life options that Cedar's City of Hope put on in Vegas. Actually, it was the first conference we were there in person. But one of the most amazing presentations was by 3 doctors from Detroit, all ER doctors, all COVID doctors. And there wasn't a dry eye in the house. But the amazing thing that came out of these ER doctors was the fact that they were talking about how important it was to be talking about palliative care and hospice in the ER. You know, ER doctors are so used to seeing their patients, getting them set and settled and on their way. Thank you. And so for the first time, they're really realizing that this discussion of end-of-life options and palliative and hospice really needs to start in the ER, no matter what the diagnosis, no matter what's happening, because things change and happen too quickly. So we want to have those discussions early. Great, thank you. Now let's see if it will let me. Oh, it's not. Okay, so as much as we've been talking about getting advanced directives and getting all this paperwork ready, there was a study that came out from JAMA this year that said, you know what? These care plans, they haven't really been as good as we thought they were going to be. And one of the reasons is that, yes, these plans change and the patient changes, the circumstance changes. And so we need to really think of advanced care plans and this advocate that we have with us as an ongoing discussion. It's not just something and done that you do when you're doing your trust. You should look at it every year and you should reevaluate it all the time, okay? So, and I wanted, next slide, please. I wanted to also be a part of a document that talks about a number of other things, not only just advanced care planning, but COVID and dementia. And we'll talk about that in a little bit. So first, who is this person who's going to be your advocate if you can't speak? A lot of times we're going for our siblings or a son, a husband, and we have to think that that may not always be the best person. Sometimes you want to make sure it's that person who can stand up for you and speak up for you. Even when someone is recommending something, you know that this patient would not want. And we all know that that happens much more than we'd like to think that it happens. So it's all right to name who you don't want. Is it someone who lives nearby? I've had patients whose family is all on the East Coast, and they choose a friend, even a young neighbor that was nearby, who was an amazing advocate. Next slide. So, so not only are we going to treat this as an ongoing process, we're going to look at it from year to year. You're going to remember Medicare now pays for these discussions with your doctor. So let them know you're coming in just to talk about your plan and some of the things that you want and don't want. You want to find out whether your doctor is going to be with you for your care plan. Do you have the same values? There are some people that, you know, if I'm in a diaper, if I'm not able to walk, if I'm not able to do all my own daily dressing, I'm done. And what are those barriers that is going to make the difference for you, for your quality of life? Go over it each year, sign it. And I now recommend that people also make a video. We're going to talk a little bit about dementia and how we feel about dementia. And the more you have maybe a video of yourself talking about how deeply you feel about these things, the stronger your family is going to feel about supporting you. The greater comfort they're going to get that they made the right decision. Okay, next slide. I think it is, so, okay, name the person. That pretty much is the same stuff. The next one, please. So I think TV and medicine has really done us a disservice, because everyone sees these full codes that happen and they intubate the patient, and then we have a couple commercials, a discussion and a resolution, and pretty soon the tube is out, they're sitting up and they're talking, and you know, that's not the way it happens in real life. You know, on TV, there's a 90% success rate of a CPR and full codes on TV. But in reality, it's really below 18%. And so you really want to think about what is this you want in terms of CPR, your DNR, and those documents. Remember, if you have an out-of-hospital I don't want CPR, I don't want DNR, it really means that in those patients, oh, these are the statistics for those out-of-hospital CPR. In the general populations, it's 2 to 17% survival to discharge from the hospital. In a long-term care solution, it's 3%. So an unwitnessed arrest is even less than that. It's less than 1%. So if someone has a DNR, when the paramedics get there, it's not like they're hands off. They're still going to administer oxygen, position for comfort, suction, control any bleeding, provide some emotional support. And so just be realistic about what you're asking for. The next slide. So there's also addendums that we're going to add on to this document that's going to talk about some other scenarios that are important. But what we've learned about advanced directives now is it's not so much the paper and what's written on it, it's about the people who have this enormous charge for you and how they're able to communicate what your goals are. You want to make clear statements, you know, don't use vague language at all. And again, use that video about what you want and what you don't want. So to help be a little more specific about what we want and don't want, we're going to add some extra paperwork and documents onto our advanced directive. One is going to be a discussion about dementia, and I can do a whole separate talk on that. I'm going to show you some web pages from Compassionate Choices site, and these resources are all going to be available to you. But basically, when you think of someone who has dementia and the different stages, you know, there comes a stage where they don't know anyone, they're not really eating, they're not really taking care of themselves. So you can write in this addendum how you feel about each of those stages and what you would want at each stage. Next slide. It can be, I don't want a ventilator. I don't want tube feedings. I don't want antibiotics if I get pneumonia and I don't know your name or my name. So these can be very specific and they're very, very helpful. I think we'll get to them in a second. This is just talking about the video. And remember, advanced directives are a video if no one knows where they are. Now there's a number of services, online services, where you can have your advanced directives. Make a copy of your advanced directives, make sure your physician has them, of course, your healthcare advocate. You can put them on these, I have the websites on the sites, and I'm going to give you the links to them. They're either a nominal fee or one may be free, caring.org. And I think California Public Health has a site also. But again, we're going to update them. Next slide. You can probably go a couple there. Let me just review. So the other addendum we're going to make sure that we add is one for dementia and another one having to do with COVID. Now, COVID has changed a lot since we first discussed this a couple of years ago. I think we had to really make a decision whether you were going to stay home or go into the hospital. But understand your risk factors. Understand what you would want if you did indeed get COVID. You can stay home much longer than you thought, and we can do a lot of the oxygen interventions at home, as well as the intravenous medications that we're giving also. So remember, you can change them at any time and redate them and adjust them. Let's go, there should be one or two we're gonna get to. I just want to touch on Pulse also. These are the websites that can store them. They're also really great about making sure that you have your advanced directives and your paperwork set up the way you want to, and then you can upload them. If you don't have them, I'll always, if you want to do a Zoom call one day with me, you can sit here with our glass of wine and go through this step by step and really talk about all the intricacies and make sure that you understand all the different issues and what you want and don't want, and make sure that it's written down. But I want to touch on now, I think, see if it's the next one on Pulse. Oh, this is the a sample page of what the COVID toolbox looks like. So if you can go to the Compassion Choices website, it has a whole page on the addendums, different questions you might want to ask, and you help to use that as your addendum. Would you want to be on a ventilator? Would you want to try the ventilator, and how long? And make sure that you have a discussion with your doctor in terms of, and remember, a lot of times you've gone to the hospital if you have a pneumonia or a COVID and you're going on the ventilator. For a lot of patients, it's very, very difficult to ever get on it. So it's often based on how old you are at one point. But hey, I'll tell you, I was 40 having horrific migraines. My husband was sick at that time. I had a migraine with so much nausea and vomiting that I ended up with, oh, that's interesting, aspiration pneumonia, and I was on a ventilator for a week. All right, now how did we get that there? We told you we had these mystery pages there. Can you see that? No, I can't get
No,
it.
I don't think we see what you're seeing. We're still on the COVID-19 Advanced
All right.
Directive addendum.
All
And then
right.
the next slide is the
Next
new
slide.
Dementia Tools.
Yeah, the next slide is an example of what the Dementia tools are. There is a Dementia platform that helps you when you're first exploring diagnosis with your doctor. And then there are probably a couple of pages that show you the dementia addendum. You could probably next and next. But I want you to get an idea of what it offers too. Again, just basically saying some of the things that we sometimes see with dementia patients that we might change our mind about fluids, infections, and not using antibiotics. Now remember, we're then going to switch to pain medications, morphine. We're always keeping the patient comfortable, but a lot of times as our body starts to shut down, giving extra fluids and extra food makes it much more uncomfortable for patients because there's nowhere for that food and fluid to go. So that's another one of the reasons why we like to cut back when patients are telling us that they're really not ready to eat and want to eat. Okay, next slide. So this is just a little bit on the California Pulse, and this is the last part of the advanced care documents we want to be aware of. It stands for Physician's Orders for Life-Sustaining Treatment. And anyone who has a chronic illness or someone who we think may be, we wouldn't be surprised if they died in the next year, or again, someone with an underlying process, and we want to make sure that we're getting our wishes followed. Next slide. So this is meant to be filled out with your physician, or it can now also be filled out with a nurse practitioner or a physician's assistant, but you're going to do it together. I like to have you download it and look at it so you understand what's there. So then when you get in with your doctor and you get it signed. This is the one form that if EMTs were called, they're going to look for it on your refrigerator. If you're in assisted living, they're going to look for it in your room. But a lot of times you hear stories like, oh, I had all my paperwork there. And then the EMTs showed up and they weren't going to pay any attention to it. And then I went to a Catholic hospital and they really didn't even want to look at it. But if you have a pulse that says what exactly you want and don't want, and it's signed by the doctor, you will find that they will pay attention to it. And most often they'll call the presiding doctor. So, but it's asking you if you want CPR, if you want a drug CPR where they're just getting medications, do you want a full code? Do you want intubation, not intubation? What medical interventions would you want? Also ask if you want some to try them out. So it's really, it's a great form. They call it different things, and it's really across the country now. In New York, it's called a MOST. It can travel with you. It definitely should travel with you from home to hospital, if you're at assisted care, to where you are. And again, this is anything that has anything on it that you've signed can be written and started over at any time. So other than that, as long as the signature is there, it's good for a while. So next page. And I'm going to give you the link to all these so you can download them. Okay. I think I addressed all those. Next. So again, we call these people that are the step-in people, surrogates, durable power of attorneys for healthcare, healthcare proxy, your agent, any of those names, they have to be 18. And again, you can say who you do not want to. And I always say make a backup also, okay? But don't surprise them. Let them know that they are, and you want to look at it again every year, or if there's a change in your diagnosis or other situation, and people move, phone numbers change, but you can, I always say, like on your birthday, if they totally agree, sign it again and say, I've reread this, I wholeheartedly stand by this, and I want this, X, Y, Z. Again, it just makes such a huge difference with your family, and there's no better gift to know that you've made the right decisions. And I'm telling you, having it on paper is really helpful for a lot of family members, because often you're finding physicians who want to treat, or, you know, you've heard the stories, you know, they want to operate on someone who's 99, the family's going no, and so it's good to have it all there. Next. So what are we planning for? Really, what are some of the options that are out there? So when we're talking about end of life option, everybody has the ability to decide their own outcome. They get to decide what they want to do, where they want to go. Every adult has a right to refuse unwanted treatment, and in this case, you can ask for all the treatment you want. Whatever you want it's there for you, but you also have a right to change your mind at any time. Next slide. Here, just click again. I think it fills in. And at any point, or you can wait, you can discontinue or decline. And this can be anything from the next round of chemo to cardiac catheterization to dialysis. I often have patients who come to me and say they're done. They don't want any more dialysis anymore. Or, you know, how do I decide? In my patient advocacy role, we'll go and we'll sit and we'll figure out, you know, we watch all day on TV the commercials about this new drug and that new drug. And oftentimes we're getting 2 to 4 more weeks of life at what quality. And that's what it's so important about, figuring out what the quality of life that's going to make the most sense for you. And so you can always choose what can be done to your body. And remember, when we're declining medical treatment, we're not stopping care. Okay, we're going to always go the utmost of care to make patients as comfortable as possible. So in terms of palliative care, I like to call it like hospice light or the beginning of hospice, but also palliative has come around for those patients with a chronic illness or where symptom management really has to be at its highest. And often as we age, we have a number of disease processes going on. Having one person managing all the different treatments is such a good thing. So if we have that, we have palliative care, and we really want to work on easing patients' concerns for day-to-day living, make sure that their pain is managed as much as possible, that the patient and the family are able to experience the best quality psychological and spiritual needs. We want to make sure we're looking at culture, but get the essential components of daily living at the utmost of care. Next. So the other options available to us are going to be hospice, sedation, and voluntary stopping of eating and drinking. And voluntary stopping of eating and drinking is a legal right for any individual who wishes to shorten the dying process by refusing nourishment. Often the patients who will choose VSED are those that can't use other means. Often it's a neurological disease, sometimes dementia, sometimes Parkinson's. And again, as I spoke before, as our bodies begin to shut down, the GI system shuts down, our ability to need and want food slows down. So it's not starving ourselves as much as hastening that disease dying process, moving the body quicker into a coma, and the coma then leads to death. And it's best done under medical supervision with hospice and other palliative care. We can really offer a compassionate way for people with dementia and to stop eating and drinking. When you're on hospice, you're able to give other medications that help to dry up secretions, to make them comfortable and peaceful. We, instead of, you know, food is such a loving, nurturing thing for life, but we try and work with families to make sure they're getting whatever music they want, that we're working with touch and voice so that some of their memories are coming back, and massage. So it can really be something that someone needs a lot of good support. But free will and the ability to choose are cornerstones of maintaining quality of life, dignity, and self-autonomy. Many patients struggle with unrelieved suffering of a chronic or incurable progressive disorder. And others decide that they're simply done after 80 or 90 decades, and they want to, they've lived their life fully, and they want to choose to have control at the end. So I've worked with a number of patients with these who are using VSED, and it's a legal alternative. As long as someone is well informed, they have significant caregiving, and they have the right at any time to refuse medical, including food and fluids. So I'm going to talk a little bit about hospice and deep sedation. What's the next slide? Does it go into the, I want to talk about pain management because it comes up a little bit when we're talking about palliative care. We're going to go into hospice a little bit, but it's really important when patients are suffering for different illnesses that we approach pain management so that we get access to appropriate pain specialties. I just often feel that elderly patients at the end of a long chronic disease, there's this big fear now of opioids and, oh, we don't want them to get addicted. And I'm sorry, if you're 80 or 90, we're not going to worry about addiction. And if someone is truly in pain, they need the medication. Morphine is the one drug that is so like our natural endorphins. The body processes it very well and very quickly, but we have other drugs as well. But we want to make sure that we're addressing the pain as early and as often as needed. Next slide, I think it fills out a little bit, this one. So we want good pain management with good specialists, a good part of the palliative care. Make sure that you let different people have different tolerances, and you want to make sure that you're speaking with your doctor about what your pain tolerance is and what's important for you to have your pain managed so you can keep a good quality of life. Easing your pain is the biggest priority. Let your caregivers know when you're beginning to experience pain, and be specific and thorough as the type of pain you're getting. Let them work with, there's a myriad of different pain management specialties and ways to get around different types of pain. I know people talk about, well, I don't want to be foggy, I don't want to be sleepy. In the beginning, you may be a little bit foggy, but that definitely goes away. And remember, we have other ways to combat the fogginess. Someone at end of life, I'd rather give them some steroids and have them alert and around family and pain-free than to have them give up the pain management. So please, if it's you, make sure you're getting the pain management you need. If you're dealing with a loved one, please be educated about pain management. The last thing I'll tell you is also, pain medicine works so much better if you take it as your pain begins to start to climb a little bit. Take it early and don't let it escalate. Don't let it get to the very worst and then take your pain medication. So, and there's a lot of really good round the clock stuff then, but easing your pain is the biggest priority, so let caregivers know. And okay, next page. So then when we go into this, I think it goes, we talk about, I think I talked about the palliative sedation. Yeah, I think it's still coming up. Okay, hospice care. Hospice care is the next level. Please, please, please don't think of hospice care as where someone goes when they're dying or when they're, starting to die. Patients can go on hospice as early as 6 months or less to live, but I've had patients who they found a colon tumor and they said, no, I don't want any surgery. I've lived out my life. I just want to do what I'm doing. And they go on hospice. The nurse will see them once a week and check on them, make sure their pain is managed, and they go and play bridge and do what they're doing. And then as the disease begins to progress, we can add more care, more medication. What we always want to do in hospice is we want to be a few steps ahead. We want to make sure in the home is whatever medications they'll need if they wake up and they're nauseated in the middle of the night, or all of a sudden pain is escalated. I want to make sure that everything you would need should something happen is there at home and waiting for you when you need it. We want to make sure that that end of life process is comfortable and peaceful for both you and the entire family, that we're going to work with the whole family system so that you get the psychological benefit of what is a natural part of life, the dying process. And Remember, hospice isn't necessarily a place, but it's something that happens usually at home around here. We used to have a lot of hospices here in LA, especially during the AIDS crisis, but now there's a couple down the South Bay and Santa Barbara, but not really here. I know of a couple of boarded cares where we can go, but mostly we're doing it in people's home, and someone would die at home, and I can talk about that in a minute. But patients aren't actively dying when they go on. Sometimes they do, but I really feel that you and the family get the most benefit if you go on early. Remember, if you decide you go on too early and you go, oh, you know what, I think I want to have that surgery, or oh, I want to have another treatment, you can go off hospice and go back on again. Okay, so it is, they're provided by a team. You've got physicians, social workers, volunteers, aides who are there. You'll probably have a couple aides for the activities of daily living, bathing and all, a couple days a week. Everybody gets a different plan with hospice, and this is part of the problem that we're running into. But the doctors don't always substitute for your own. So in some cases, the hospice physicians will take over and do the ordering for everything. In other cases, your physician could stay on, and the hospice physician would just order the drugs that have to do with hospice and end-of-life care. Different hospices work differently. Other primary conditions could be addressed by the doctor. Hospice programs are proliferating in California. It's getting really bad. Quantity and the quality vary so much. And one of the big issues we're running into now is, I think I have in my notes, ask a knowledgeable person. Well, this is where I've been running into problems this year, because hospices are very easy to start up. There's a lot of money in hospices, and because of the End of Life Option Act, more people are also coming in. The weak spot in this whole system seems to be how is a patient getting referred to hospice? I have found that often patients will say to their doctor, we're really done, we're ready for hospice. And the doctor will go, oh, no, they're not ready yet. Well, if the family is asking the first time, then I found that family was probably ready a few months ago. And I've had doctors turn patients away 3 and 4 times. And then I'll tell the family, you call the hospice, have the hospice call the doctor, and then they'll refer. Sometimes you have to be more forceful and advocate for yourself when you're ready to go on hospice. But otherwise, sometimes the doctors are then referring. But then it's a matter of who are they referring to. And you really need to begin to look at what you want out of hospice. They all work a little bit differently. Some of them, especially now with the crisis of not getting enough employees, they all will make out a plan. And you have to be able to be very verbal about what you want and don't want. We're going to talk in a few minutes about medical aid in dying, or End of Life Option Act. Not all of the hospices do that. So we'll talk about that in a minute, but there are other plans, that visa that we talked about. And you may think that you may not want X or Y for your end of life, but if you're on a few months, you may think differently. And all of a sudden you found yourself on a hospice that's not giving you what you want. Either your pain isn't managed, or you wanted a massage and didn't get a massage. This is when I get phone calls now. I get phone calls that my mom's been on hospice. She's asked 5 times that she wanted end of life option, and they'll say, oh, we'll do that. Or nobody in LA does that. Or you have to live in Northern California, or you have to wait 6 months. These are all things that I've heard. So let's go to the next slide and see. But I do want to make sure that you have talk to your hospice about what you truly want. And I'll circle back a little bit to that, but you can also find all of them on the website. Let's go to the next slide. We're going to talk about medical aid in dying, which is available here in California. What is it? It's a medical practice, safe and trusted. It's used in over 10 states. When someone who has a prognosis of 6 months or less to live has the option to request from their physician a prescription for medication that they can use to self-ingest at some point of their own wishing, when their suffering has gotten to be too much and they want to be able to end their life. It's also known as death with dignity. Next slide. It is not suicide. I'll explain that in a second. But it is 75% supported in California, and most of the country at this point. Next slide. It was passed in 2016. There's now 10 states in the country that authorized it. There are the dark blue are the ones that have something in legislation in progress, and then the gold they're actually compassionate choices working at it. But Hawaii and Nevada are the newest ones right now, New Jersey. But, you know, I find more people know about marijuana. I've had patients say, you know, I was asking about that law, but it's been on the books since 2016, and we just updated a little bit. So that's one of the things I'm going to talk a little bit. So next slide. So Governor Brown signed it in 2015. It became a law in 2016. But here's the crux of it. You know, I know if I were dying in prolonged pain, certain that if I could find comfort in using the bill like this, I wouldn't deny it. And and again, I may not use it, but for obvious reasons that you'll see, we updated it in January. Next slide. Because okay, slide change. Because before the waiting period was 15 days. So you had to see a doctor twice. I went to change these around, you'll see in a minute. You see a doctor 2 times, your first oral request and your second oral request by your attending doctor or the doctor who's going to write the prescription. And before it was 15 days apart. And then in between there was a third visit by a second doctor who confirmed that you were terminal, and then the prescription was written after the 15 days. Now we've changed it to 48 hours, which sounds really quickly. And the logistics is, by the time you get those doctor visits in, and now because of COVID, let's think of a couple more good things of COVID. Because of COVID, I know all of us have probably used telemedicine in the last year. And before, instead of having these terminally ill, suffering patients getting in their car and driving all over LA to find a doctor who would prescribe for them because they wanted the medication, and the hospice they were on now wouldn't do it. And so it really became frustrating. So now to be able to use telemedicine has made a huge, huge difference, especially for patients with neurodegenerative diseases, or I've had patients referred to me with ALS. And we know that with ALS, there's a very thin line there. Once you're not able to swallow, you've got to be able to take this medication on your own and swallow it. Or I'll talk about some other ways we also allow the patient to get it in. But you still have some use of your hands. And if you've been on another hospice that's been lying to you, and now you find, oh, it's really true, I can get it here where I live. Not like Brittany Maynard, who had to go to to Oregon. So now we finally get you moved over, and you don't make it through your waiting period. And so that's what was happening. So everybody won't use those 48 hours. And in fact, 1/3 of the patients who get the medication don't end up using it. They may be comfortable just as they are. It may just be a backup plan. But I had a patient just at Thanksgiving who didn't make it. She got all the medication from UCLA, but she had to use the outpatient pharmacy, and it was closed for Thanksgiving, and she didn't make it before the end. So I was thrilled when we worked and were able to get to 48 hours. And I have 2 doctors who will help us make it in 48 hours if we need to, but sometimes logistics just make it hard. And now hospices and hospitals are required on their website to say what their policy is. Do you support it? Do you not? Now, the only thing is you have to be the consumer and you're willing to go looking on that website, because I've already found that a couple of them have them really well hidden. So the next page. But it also says if that patient who said to the doctor the first day that I want medical aid in dying and they were misled, that's not legal anymore. And also they're required to refer the patient and with their documents as soon as they've heard it the first time. So next slide. But so what are these requirements? You've got to be a California resident. You've got to be able to show proof that you're living here. It's not too high a bar, but you have to prove it. Terminally ill with 6 months or less. And often we get these patients who are already on a hospice, but again, that second doctor is going to look at the records and see what the situation is. You have to be mentally capable to make your own medical decisions, and you have to be able to self-ingest. And that means in California, we determined to mean that somebody can mix the medication and get the cup ready, but you have to be able to hold it, take the straw and drink it. Or if someone has a feeding tube, they have to either use the plunger, the syringe that pushes it down, or start the feeding tube or the IV going. That qualifies as ability to ingest. Now remember, if you have dementia, someone always says to me, well, can I put that in my advanced directive that once I get dementia and I'm at this stage, just give me that medication? No, it doesn't work that way. There was a part of the law that said a patient could need a medical evaluation, a psychological evaluation. It's not required. It is required in some states. I know Hawaii it is. Oftentimes, my brain tumor patients will get that psychological evaluation to prove that they're still capable of making decisions. Next slide. But it's not required. But some institutions will perform it. You know, people aren't depressed. People who are medically able or actively dying, you know, they're not clinically depressed and they're not suicidal. These patients all desperately want to live, but they are dying. And at this point in their life, they want to be able to control what they haven't been able to control for a long time. So the Association of Suicidology does not call it suicide. So we call it Medical Aid in Dying or End of Life Option Act. So these are the rest of the requirements. And we can go to the next one. So we use a feeding tube or a rectal tube also. Age or disability is not a factor. You can't say, and I've had a 102-year-old woman who desperately wanted to use medical aid in dying, and we could not. It was very difficult. They didn't find a reason, and then eventually there was a cardiac issue that came up. But there was another elderly lady who ended up using VSED, but the death certificate states the underlying disease process, whether it's cancer or cardiac or kidney disease. It doesn't say they use medical aid in dying. I find some families keep it very private, and some families are, you know, talking to their friends about it. I think more people are talking about it because definitely we're getting many more calls lately about it. Does not affect contracts or anything like that. Next slide. What else is here? There are some systems, like, as you can imagine, Catholic healthcare systems are not a part of it, and they have chosen to opt out. They can't prohibit staff from participating. Remember, this is not meant to happen in a hospital. It's meant to happen at home or where you want to. It can't happen in a public place. I've had patients that did it in the backyard, things like that. So next page. but anyone who chooses it is going to be, it is voluntary. I mean, I have a doctor who works out of a Catholic office building, and she's written before too. So, but if your own personal doctor says no, that he's not allowed to prescribe, or I've had patients who said, you know, my doctor said he's never done it before. That we do have a doc-to-doc consultation line. They can call, they can get information. You don't, all the forms are all online. I can get you the forms. I'm going to show you where they are. I have concierge doctors, other hospice doctors. There are hospices where the medical directors also prescribe. So you're there and you're able to have exactly what you want on the hospice you want. If you're on a hospice and you find out they don't do it, if you don't want to leave that hospice, sometimes patients are just comfortable, they've got the hospital bed or whatever they want. You can stay on that hospice. I can help you through the process and find physicians for you, which I recently did that with a patient who was on hospice, whose doctor knew from, he helped pass the law. So almost finished. I want to answer any questions you have though. So next slide. So going back to that, these are just some questions that when a doctor or a social worker says, I'm going to refer you to XYZ hospice, you may want to ask some of these questions. Do they support medical aid in dying? Will they be there with you if you want to use it? Again, you may not think it's something you want to use in the beginning, but may change your mind. And that's happened with a number of patients about VSAD or other end-of-life options. But please know you can always change hospices. It's literally a phone call. They come to you. The paperwork is about the same. It's all really, if you're on Medicare and all, it's about the same. Insurance covers it. Next slide. Insurance covers hospice, Medicare covers hospice. It doesn't cover end-of-life option. Medi-Cal does, some California plans. I've had some of the AARPs cover part of it. So in actual practice, it's two drugs, an antiemetic and an anti-secretion drug about an hour before. And then the medication is in a powder form, just in like a little Slurpee, and the patient drinks it within 2 to 3 minutes, and we find that the patient falls asleep within 3 to 5 minutes, and they're peaceful, and they go into a coma from there and pass away between an hour to 2.5 hours after that. Sometimes it can go a little longer, but it's very, very rare. Next slide. So now we can go through some of these fast. Some of those are just statistics between Oregon and here and what we're seeing, but just having that prescription can make such a difference. And I find having the law in place has now gotten more patients talking about palliative care, talking about end-of-life care a little earlier and considering some of their options at some point. Next. Again, this is, if you get dementia, no. That's why it's important to talk about it ahead of time, have a pulse, think about VSAD, look at some of the different stages and what you would want at different stages of dementia. And the resources I have are just really excellent. We can do a whole program on one of these topics because there's just such really good information there. Each year we go back to California and we submit data. And in the beginning, the numbers were really low because people didn't know about it. They couldn't find a doctor. And now it's gotten a little bit better to, it's way better now because we can help you now. But these are the numbers that how many people actually are in hospice when they take the medication, how many get the prescription, and how many actually take it. Sometimes they die before they get the prescription. And again, like I said, sometimes they get the prescription and they end up not needing it. you know, for a lot of people, you want to know, what is death going to be like? What will there be pain? Will my pain be managed? And that 1/3 of people who die before the process is completed is why it was so important to move from the 15 days to the 48 hours, so that those patients who truly, truly wanted to use this would get a better shot at it. So, oh, those were the 5 Ds: decade, death, divorce, diagnosis, or decline. So update, update, update. Next, I think we're pretty close to the end. Yeah, one of my favorite quotes, but endings matter. And we've all had too many of those endings that we don't want to be like Aunt Sally. So this is part of the COVID tool, but I'll give you that on the link afterwards. Yeah. This is just sort of a pathway of all the different stages, but completing advanced directive, sort of what the dementia addendum looks like in terms of planning. All these things are available to download on the links. And I'm going to send to Allison a printout of all the links that are there. And if there's something that isn't there, or there's something that, you know, I feel like I touched on everything tonight. Sometimes we just focus on end of life and medical aid and dying, but I just had such problems with advanced directives and people not getting what they want that I really wanted everyone to take a look at that this year too, and make sure they're person. So that's my number. That's the website. You can get me anytime, and I'm always glad to help you guys in any level and answer any of these questions. I also do patient advocacy, going to appointments and being that nurse in the family that you might not have. Okay. Anybody else have any questions? Thank you for having me again, Rachel and Allison. It was great. Sorry for all of our technical glitches this morning. You'd think we do this so many times, it wouldn't be a